Bye. Hello and welcome to Knock Knock I with Dr. Glockenflecken. This is a little different, right? We're releasing this on a Thursday. Normally our episodes are on Tuesday. It's just me. I'm alone in my office here recording, and it's called Knock Knock I because this is not a Knock Knock Hi. We're just talking eyeballs today. This is one of my favorite things in life. Are eyeballs. Did you know that? See, the thing is, a lot of people don't realize I am an ophthalmologist. That surprises people because they see me spend so much time wearing costumes and pretending to be other specialties in my content that they don't know I'm actually a board certified ophthalmologist. I've been practicing. I finished residency in 2017. So I got about 7 years under my belt here. And so I've heard a lot of feedback from people. I might put a video out about general surgery or turnover time or internal medicine rounds, and I would still get comments from people like, "Hey, can you explain idiopathic intracranial hypertension to me? Can you tell me about the latest eye drop that's causing that people are murdering other people with?" Visine. The point is, we could talk about that later. The point is, I get so many questions about eyeball stuff, and I don't know why I don't. Actually, I do know why. I don't address ophthalmology topics very often. I'm not the type of content creator that historically has done a lot of just straight up education about eyeballs. Because this has always been like my creative outlet, right? I do that all day in clinic and surgery. Like I'm always talking about eyeball stuff. And so this is like my chance to just do comedy, maybe a little education, but things that are outside my comfort zone. I love stretching myself a little bit, having to actually learn about, nephrology topics or infectious disease topics, and try to make them funny. That's fun for me. I know that's a weird thing to say out loud, but it is fun for me. It's my creative outlet. But I've really been thinking, okay, I have this platform. I have so many people that want to know about eyeball stuff. But also there's a lot of really strange things that people are saying about eyeballs on social media. There's a lot of misinformation. There's a lot of bad advice. And I trust myself with my ophthalmology knowledge. I would hope that you would trust me with ophthalmology knowledge. So I thought, you know what? I'm doing a disservice to society by not talking about eyeballs. No, I don't know. I want to use like my platform for good. And so I like talking about the U.S. healthcare system. So why not talk about eyeballs? All right. Now, some of you may be like, I don't care. I know that I have 2 of them. That's all I need to know about eyes. And that's fine. That's fine. But I'll try to make this fun and interesting. Now, it may be topics that you don't care about. There may be topics that you've heard about, but you do want to learn about, but you don't know anything about. That didn't make any sense what I just said. The point is, like, some of you will like this. Some of you will be like, to hell with it. I don't want to know anything about eyeballs. And that's fine. All right. What we're going to do, I'm going to choose one topic, one ophthalmology topic, one disease, one thing, and we'll go in depth into it a little bit. And I guarantee you'll learn something. You really will learn something because nobody outside of ophthalmology knows about eyeballs or really cares to know about eyeballs. So whether you like it or not, you're going to learn something about eyeballs. All right. That's our goal here. It's going to be fun, though. I promise. Actually, I can't promise that, but I'm going to do my best. So the way I thought we could start this, and again, every week, once a week, for as long as I can keep this up, we'll see. Every time I like start a project, I think, you know what, this is going to be great, but I'm done. Like this, I can't fit anything more into my schedule, and then I get pulled into something else. And so like I got my career as an ophthalmologist. I'm making the skits. We're doing the podcast I'm recording with my wife, Kristen, and then now I'm doing this. And it's just like there are only 24 hours. Actually, there are. I think neurosurgeons have figured out that there are actually 28 hours in a day. Did you know that? I think that was recently published in JAMA. I don't know. Anyway, the point is, I'm going to do my best to keep this going. We'll see. If I start, losing my mind and getting burned out, I'll stop. But I think this will be fun. And so as we go, I'm going to be developing this little once a week series. And we'll see what happens. If you have suggestions for improvements or suggestions for topics you want to hear me talk about with regard to ophthalmology, we may touch on some non-ophthalmology areas of medicine as well. Just like anything, this will evolve, and I'll try to make it as fun and entertaining and educational as possible. So what I thought we could do, I want to start with a short series over the next few weeks about PANS patients. This is going to be the topic. The topic will be a different PANS patient every week. Now, I keep saying that as if you all know what I'm talking about. Some of you may know because I think I've mentioned PANS patients before, but if I haven't, a PANS patient is when you're on call as an ophthalmologist and the emergency department pages you. You call them back and they tell you something about a patient that results in you immediately putting on your pants and coming in to see the patient. So, PANS patients are the true emergencies of ophthalmology. Now, fortunately, there are not that many. If there were more actual emergencies in ophthalmology, I wouldn't be making TikToks every other day. But so fortunately, it's not that frequent that we have like true emergencies where I got to like get up, come in at 2 a.m. to assess, to evaluate the patient, to treat the patient, do surgery. So we are going to start once a week with a PANS patient. This is a disease, something that happened that's resulting in me immediately coming to evaluate the patient. So I'm going to set these up with a patient presentation. This is typical of a typical presentation of the disease, but I'm not, these aren't like actual patients. I'm not, using any real patient information. So we don't have any like HIPAA issues or anything. But these are all things that we see fairly commonly. Eventually, we may get into some really uncommon, some zebra type stuff, but we'll start pretty common here. So this patient is a 58-year-old male who was at home, very artistic individual. This is just a lovely gentleman. All right, he just he's got a very eclectic taste, lots of different hobbies. And one of the things he likes to do is he likes to make artwork, and he likes using his hands. And so he's doing some metal working. He was grinding, he was hammering metal, using his grinder, using his like table saw as well for other things. And you know what? He forgot to put on his safety glasses. I think you can see where this is going. There was an accident. A piece of his equipment broke off and high-speed projectile right to the eye. And then he went into the emergency room. The emergency department, they evaluate the patient. They got a CT scan. And I get a call in the emergency department. I ask, well, what's the patient's vision? That's the number one thing. If you call an ophthalmologist, you got to have some kind of vision assessment, please. All right, we don't get angry very often because let's be honest, our life is not bad, all right, as far as like on-call duties. And so no ophthalmologist really should ever get upset with you for like calling. But the thing that does grind our gears a little bit more than anything else is when you call us, but you don't have a vision. And it's not hard to get a vision. So for this patient, let's say the emergency department, they did get a vision. They lifted up the patient's eyelid and the patient saw no light. No light perception. A lot of people think if you're checking vision, you're putting a chart in front of the patient's eye. You're like, what can you read? Well, if the patient can't read anything on the chart, there's still a lot of useful vision that you can assess for. You can put your hand in front of their face. You can do hand motion vision. Do you see my hand moving? Do you see fingers that I'm holding up in front of you? If they can't see any of that, then you find a big bright light and you shine it right in front of that patient's eye. If the patient cannot see that light, that is called no light perception, and that is a big deal. There are very few things that cause that level of vision loss. One of them is an open globe injury, and that is what we're talking about today, open globe injuries. So you can think of the eye as a balloon, right? And so if you make a hole in the side of the balloon, it's going to deflate rather explosively for a balloon, not so much for an eyeball, because the eye is not filled with air. There's no air in the eyeball. It's filled with fluid. It's filled with jelly. You definitely don't want a hole or a scratch or a laceration to the side of the eye or the front of the eye, any part of the eye, because then the things that are inside the eye will come outside the eye. And so the emergency department, they call me. They say, no light perception vision. Immediately, my ears are perking. I'm waking. I am now fully awake. My feet are out of the bed. They're they're hanging off the side. They're on the floor. I'm starting to look for my pants because I know that there's something serious going on because there's no light perception in that eye. The ED says, we got a CT scan. It's like, good. We always want a CT scan for any kind of eye trauma at all whatsoever. They say, it looks deflated. And we actually have a word for that. We call it the smushed grape sign, or at least I call it a smushed grape sign, because on a CT scan, the eye should be spherical. It should look whole. But if there's an open globe, it can look a little bit smushed. Now, you can't diagnose an open globe just based on that CT scan. You do have to actually look at the eye and find out if there's a laceration or a puncture wound or something. But it's certainly something that helps us with our diagnosis, especially when it's a non-ophthalmologist. So, that's actually enough of a presentation from the emergency physician for me to get my ass out of bed and get up to the hospital. Because no light perception with a history of trauma, that is an open globe until proven otherwise. All right, I have to assume that's an open globe. So I'm going in, I'm checking on, I open up the patient's eye, and sure enough, there's a laceration to the sclera. The sclera is the white part of the eye. All right, so laceration to the sclera. First thing I'm doing, putting on a shield. You got to put a shield on the eye. Next thing I'm doing is I'm looking to see if there's any imaging. Now, there's already a CT scan. That's good. You may hear about ultrasound for traumatic eye injuries. There's never a need. There's never an indication to put an ultrasound probe on a traumatic eye injury. Now, I've had arguments. This is one of the things, all right? As like one of the only like ophthalmologists that people know about on social media, I for a long time every so often I get pulled into like an argument. And a lot of them, a big one is about using ultrasound. In general, I'm fine with you using ultrasound in the eye. Emergency medicine doctors, they like doing this. But it's never indicated or necessary for a trauma. Because it doesn't matter what you see on that ultrasound, we're going to need a CT scan. And I can see more with a CT scan than you can with an ultrasound. Trust me, all right? We can evaluate for orbital fractures. We can also evaluate for any intraocular or intraorbital foreign bodies, metallic foreign bodies. An ultrasound can see foreign bodies in the eye, but it has a hard time seeing foreign bodies in the orbit behind the eye. And we need to see both. So, got to have a CT scan. You got to have it. So I go in there, I put a shield on the eye. We don't want anything hitting the eye at this point. There's an open globe. All right. We don't want the patient trying to rub the eye. So we put a shield on there, make sure there's a scan, give the patient Zofran. Why would we do that? We don't want any nausea or vomiting for that patient, because having a patient with an open globe start vomiting is the easiest way for whatever's inside the eye to end up outside the eye. All right. You're just going to push out all the stuff, all the important structures in there. This is going to get gross, by the way. You'll find a common theme with eyeball stuff. All right. If you might feel a little squeamish. But we're gonna talk about all the stuff, all the gross things with eyeballs. All right, I'm not showing you pictures. You can at least take solace in that fact. You can if you want, though. Just Google open globe injury. It's horrifying, most of the time. So anyway, I got the shield on there. We got the scan. Zofran. We're starting IV moxifloxacin, 400 milligrams. So we always give IV moxi with any open globe injury because it has good intraocular penetration. That antibiotic will get through the bloodstream. It'll get into the eye and kill all the. It's a strong antibiotic, so it's broad spectrum. It's going to kill a lot of things. And that's one of the things we're most worried about is infection. And then after we get the IV moxi going, and then we're planning the operating room. We're planning what we're going to do. We try to. This is in residency. This would be what we call the Class B case. So it needs to go to the operating room within 4 hours. You'd be surprised. Some people think, "Oh man, don't you have to go like right away?" It's like you see in the medical TV shows. They're just wheeling you up immediately. The surgeon, everybody's there right there. The music's dramatic, but no, we can wait a few hours. In fact, sometimes that's advantageous because if it's like 3 a.m. and we can wait a few hours for like our typical eye team, because this is very specialized surgery. If we can wait a few hours for the eye team to get there, it makes the surgery a little bit easier. It makes it go a little bit more smoothly. So we do like that, but if we need to, we'll go in the middle of the night. Repair the eyeball, so use little tiny sutures. If you know anything about sutures, like the general surgeons use like 3-0, 2-0, 1-0, 0-0. I don't even know how low it gets. We're using like 9-0, 10-0. We're using a microscope, very fine surgery, and sometimes these open globes can take several hours to fix, depending on the extent of the injury. And then, so we repair the surgery. So we repair the eye, and then it's a lot of follow-up after that. I'm not going to go into like the post-op drops or anything. That's a little bit too ophthalmology specific. I'm not trying to make this be something for ophthalmologists. I want this to be an everybody type. Everybody can enjoy a little open globe talk. Everybody can enjoy a little smushed grape talk. And so there's a whole post-op treatment regimen that we go through. The prognosis is not great for most open globe injuries, especially if the eye is no light perception. All right, so if the patient's not seeing anything pre-op, there's a good chance they're not going to see anything post-op. It's a really bad injury. We do our best. We repair the eye the best we can, and then we kind of just see how the patient heals up. But a lot of the times, patients end up having those eyes enucleated, which means removed. You put a prosthetic in. It's another topic we can talk about later. The ones that do well are the ones that have the patients that have good vision preoperatively. So they're small lacerations, like little corneal lacerations, puncture wounds, things that we can that are typically lacerations in the front part of the eye that don't go deep. They get into the eye, but they stop short of causing damage to any vital structures. Those, we can save those eyes, and those are the very lucky ones. So that's open globes. Now, this brings me to our, I'm going to try to do little segments. So this one's the Don't Do That eyeball tip of the week. Part of the reason I'm doing this is because every so often I get tagged on something on TikTok and it has me screaming out, "Don't do that to your eyeballs." I don't know why people love like messing with their eyes, just like doing like squirting lime juice in their eye and using aged urine eye drops. Yes, these are real things. We can talk about them as we go through this weekly series. So this is something as the Don't Do That eyeball tip of the week. Today's Don't Do That Eyeball Tip of the Week. Wear safety glasses, please. It's, so much in life would be safer if we all just wore safety glasses. All right. So when you're doing metalworking and woodworking, obviously, when you're doing yard work, all right, if you're mowing the yard, you're cutting limbs, you're weed eating, you're out there, you're eating weeds. Put on some safety glass. If there's a projectile, if there is a risk of projectiles, wear your safety glasses, okay? Shooting off fireworks. I see it every year. People just doing, you know, if you're doing anything more dangerous than like lighting a one of those black snake things, the, the the charcoal snakes, that just slowly. If it's anything more involved than that, wear safety. In fact, even if you're just doing the charcoal snakes, still wear your safety glasses. You never know. You never know, folks. So yard work, metalworking, woodworking, fireworks, driving a car. Yes, it might sound ridiculous, but I wouldn't fault you for putting on safety glasses when you get in the car. You, d- you can do what you want. You want to be safe. It's something to think about. All right. Visiting the zoo. Why people don't walk around wearing safety glasses at the zoo, I don't know, because any animal, a tiger, you'd think those enclosures really keep you safe. I mean, if they wanted to get out, let's be honest, if there's an open air exhibit with a tiger, if it wanted to escape, it would escape and it would maul your face off. All right. But if you're wearing safety glasses, you'll be you probably won't be fine. But the point is, it never hurts to err on the side of safety, of caution. All right, and that's what I'm all about when it comes to eyeballs. All right, here's another one: using a curling iron. I've seen it. I don't know. Maybe you get too like vigorous with the curling of the hair, and it gets your eyeball. I've seen burns, some nasty injuries. I put on some safety glasses when you're curling your hair. All right, you could probably post a TikTok about it. It'd probably go viral. There you go. There's free content advice for burgeoning content creators here. Safety glasses while doing all of these things. Hiking, walking, living your life in general. I can't think of this is really devolving here, but I can't think of a reason not to wear safety glasses doing anything whatsoever. Um, that sounds unreasonable. I realize that, but you got to go with me on this one. All right. So if you ever think to yourself, should I? There's a thing in surgery when we're doing eye surgery. And there's like little devices, little things you can use to may help you feel better. I'll use like pupil expansion devices. We use these if the patient's pupil doesn't dilate enough, we can use a little device to open up the pupil. And one thing my mentor taught me, Tom Oding at the University of Iowa, shout out Tom. One thing he told me was that if you think about using it, then use it. If you think you might need it, then use it. All right. In surgery, I think it applies in life as well. If you think to yourself, oh, I should probably be wearing safety glasses. Yeah, you should wear safety glasses. Put those things on. All right. I don't want to see any pictures of any of you using sparklers without safety glasses. Okay. So that's your don't do that eyeball tip of the week. Wear safety glasses as often as humanly possible. All right. Now it's time for your ophthalmology fun fact. We're wrapping this up. I promised you I wouldn't go longer than like 30 minutes on this. Did I promise you that? I don't know. I'm promising that to you now. All right, your ophthalmology fun fact of the week. All right, this is related to the size of your eyeball. Now, a lot of people think this is like something I probably heard in like elementary school, right? So it's like been perpetuated over time that your eyes don't grow as you get older. Like you're born with like adult-sized eyeballs, which would be interesting to look at. Actually, there are diseases like congenital glaucoma where the eye will be much larger, and it's a tough disease. It's an abnormal finding, and so no, that's not true. The eye does grow over time. In fact, your eye when you're born is about 17 millimeters long. 17 millimeters long. The adult eyeball is about 24 millimeters long. So your eye is roughly 66% of the size it'll be as an adult when you're born. There you go. There is your eyeball tip of the week. Something you can take to parties. Make sure everybody's good and drunk before you pull that one out. Otherwise, they'll look at you funny. So there you go. The eyeball tip of the sorry, that's not the ophthalmology fun fact, not the eyeball tip of the week. I'm getting my segments confused here. All right. And if you have other again, I'm just going to keep reminding you, give me some ideas, things that you want me to talk about. I'm happy to oblige. All right. And the last thing, here's the last segment. And if I can think of more segments over time, we'll do it because I think they're kind of fun. All right. This last segment that I'm going to do every week, it's called Explain Like I'm 8. Now, if you went through medical training, medical education, probably anything, you know that when people who are much smarter than you try to explain things, sometimes it just goes way over your head. Like I can think of so many times when I had like a cardiologist or a nephrologist or particularly nephrology, because their stuff is so complicated. I was a med student. I was listening to this presentation, and the nephrologist was explaining something, and I came away thinking, man, I have no idea what you just said at all. And I wanted to so badly just say, can you do that again? Instead, pretend I'm an 8-year-old boy. Pretend I'm 8 and explain it to me in words and ways that an 8-year-old would understand. So that's what we're going to do. It's called Explain Like I'm 8. And not only am I going to explain it to you like an 8-year-old, like you're an 8-year-old, but I'm also going to have a question asked by an 8-year-old. So the question is going to be from an 8-year-old. The answer is going to be for 8-year-olds. All right. And hopefully we can all learn together from this. All right. So here we go. Here's a question from actually my 8-year-old. Here we go.
What's behind the eye?
That is a fantastic question. What is behind the eye? What's back there? So the eye sits in an orbit. So the orbit, if you've ever seen a skull, right? You know the space where the eye goes. It's like like a little home, but it's got 3 walls. Well, really 4 walls, right? It's got a roof, it's got a lateral, it's got an inferior, and it's got a medial. So it's surrounded. It protects the eye. All right. So the eye sits in the orbit, but it's not all the way in the back of the orbit. There's space behind the eye. That's where all the blood vessels are, the lymphatics, the muscles are back there. There's nerves. The optic nerve is back there. And so there's actually a good amount of space back there. And so, that's the orbit is a very complicated structure. So that's behind the eye is the space called the orbit. We call it also the retrobulbar space, the behind the eye space. And then if you go further and further back, then you get to the back of the eye, the back of the orbit, which is then if you go behind the orbital apex, which is where all those bones, they come together to form the back of the orbit, then you get into the brain. All right. So all the blood vessels, all the nerves, everything, they go from the eye all the way to the back of the orbit, and then there's little holes, little slits where those blood vessels and those nerves can get out of the orbit and go back to the brain. So that's the space behind the eye. Thank you for that question. And if you have other questions that you'd like me to answer, like you're an 8-year-old, please let me know. I'm happy to. I want to try to keep things simple. I want this to be something we can all learn from, right? I want you all to learn something about eyeballs. So that's our episode today of Knock Knock Eye. Thank you all for joining me. I promised I wouldn't go over 30 minutes, and we're like just barely there. So stay tuned next week. We'll do another pants patient. Thanks for joining me. Take care, everyone.